Okay. So good evening, everybody. Thank you very much for spending time at the AHN Fireside Chat today. We today have a wonderful speaker from within Africa, a very well-known youngster and the president of the Young AFRAN, Elliot Tannor. Dr. Elliot Tannor is a senior lecturer in the Department of Medicine of School of Medicine and Dentistry at the Kwame Nkrumah University of Science and Technology, and a senior specialist physician and consultant nephrologist at the Komfo Anokye Teaching Hospital in Kumasi, Ghana. He's a fellow of the West African College of Physicians and fellow of the International Society of Nephrology after training in Cape Town, South Africa in 2016. He's an educational committee chairman of the Ghana Kidney Association and the chairman of the Young Nephrologist Committee of African Association of Nephrology. He's a member of the AFRAN's COVID-19 working group and a member of the ISN DOPS COVID-19 survey group. He's a member of the ISN Education Committee and part of the first cohort of the Emerging Leaders Program of the International Society of Nephrology. So he's one of the 14 people selected by the ISN as an emerging leader and underwent and is currently part of it and is going through the training, and Nick is along with him as well. So they are colleagues there. He's a senior Atlantic Fellow of Health Equity with George Washington University, championing health equity in access and management of kidney disease in Ghana. He's a founder, CEO of the KidneyHealth International, a local NGO promoting kidney health in Ghana and beyond. He has 23 research publications and written 17 educational online publications on kidney disease promotion. He is a kidney health advocate, a health promoter, and educates the general public about kidney disease and its prevention, which is a very important thing not done very commonly. He has organized free kidney health screening for over 3,000 people, set up renal management teams in 5 district hospitals in Ghana, visited 13 radio stations, 9 television stations, and 23 organized groups, educating on kidney disease prevention in the last 4 years. He has written a book on how to prevent kidney disease, which has been launched in 2 regions in Ghana. Dr. Tannor is a principal investigator of the KNUST site for the H3 Africa Kidney Disease Research Network. This is a big multinational African study recruiting over 7,000 subjects in chronic kidney disease and controls. This study will allow understanding of the contribution of ApoL gene variants to the development of CKD in Black Africans. He is married with 4 blessed children and learning how to play the piano. That is wonderful. So, Dr. Tannor, it's a very distinguished career, and I think you've done a lot in nephrology, and now we wait to listen to you on the state of the art of diabetic kidney disease. Thank you very much. The stage is yours.
All right, thank you very much, Lloyd. I mean, you made it sound very big, but guys, it's just me, and this is not a one-way lecture. It's going to be a discussion. That is why I'm hoping to get things done quickly so we can get to discuss what is pertinent so far as Africa is concerned. Of all Lloyd mentioned, the only one I'm passionate about is the fact that as in Africa, we should be very passionate about the prevention of kidney disease. And that is where I am really passionate about. So wherever you are, whatever you do, it's not just about just sitting in your hospital and putting in catheters and, making bags. It's about getting out there to ensure that the next person does not get kidney disease. So thank you all for coming. I think we are full. It's 100 now, and it's amazing that we've been able to pull such crowd. I think diabetes is such an important thing to discuss. Let me just share my screen. We are just going to discuss diabetic kidney disease. And indeed, it's such an important topic. And we are going to talk about what is new or state of the art. It sounds really glorious, but I think the most important thing is just to pick 1 or 2 things so far as kidney disease management is concerned. I have no conflict of interest. And indeed, when we talk about new, sometimes it's new is relative. It could be new in terms of yesterday. It could be new a year ago. It all depends on how or what you know so far as the management of kidney disease is concerned. I'm actually going to talk general terms and then, of course, what has been discussed internationally so far as the management of kidney disease is concerned. So my way of objective, I just have 4 objectives within the next 35 or 40 minutes, where we are going to just quickly discuss the burden of diabetic kidney disease, basically among type 2 diabetes. That's what we worry about the most, I believe. And then we'll talk about the general management of diabetic kidney disease, where, in my opinion, that is what the majority of us will be doing, depending on where you are practicing. And then the prevention of diabetic kidney disease, where I'm actually really passionate about. And then we'll talk about what is new. And what I ask all of us is that, is there a triple renal protection here? And I think that is what will take a chunk of my discussion this evening. All right, so just a bit about, this is not new. This, I believe you know already, that diabetes is such a big problem worldwide. About 108 million somewhere in 1980, where prevalence was just 4.7%. In 2012, it shot up by double, about 8.5%, and it's believed that some 640 million people will be living with diabetes in the year 2040. The worrying aspect for you and I is the fact that it is rising faster from where you come from. And I'm sure wherever you practice now, you see a lot of diabetics. Indeed, it used to be said that, oh, this diabetes is just for the rich and all, but you can bear with me that there are people who are not rich and they are still getting diabetes. What is the situation in sub-Saharan Africa? So indeed, in about 20 to 79 years of age, about 24 million people have diabetes, and it is killing a lot of people so far as the African region is concerned. So this is current data in terms of 2021, where about 416,000 people died as a result of diabetes. So that is worrying. The danger is the fact that the highest proportion are undiagnosed. So whatever we know is half of the story. Indeed, in some studies, it's about 2/3 of the story. We don't know anything at all, and all we know is probably about 1/3. So the key is that there are a lot of people who are out there who have diabetes, and they don't even know that they have diabetes. And if you and I, as nephrologists, they will come as our patients somewhere along the line. Now, how about diabetic kidney disease? So most patients, wherever you are practicing, I'm sure you have some diabetics on your machine. Worldwide, indeed, happens to be the chunk of people on dialysis. Where I work in Ghana, for instance, and I believe might be the same, it happens to always be the second in terms of the prevalence. But what we know is that a lot of our people are coming in, they are not diabetics, they probably might have hypertension, and they would have shrunken kidneys, and depending on how you'd want to call them, you either say that they had the CKD from hypertension, or probably from a chronic GN, or indeed, if you want to be very blank with yourself, you probably will say that, oh, kidney disease unknown. But then what we know is that a lot of our patients will come with nephropathy straight, as newly diagnosed. So you are seeing them for the first time with an HbA1c that is high, and then you realize already that their creatinine is in the roofs and it's not acute in nature. Probably it is all nephropathy. And the severity is more in Black. So if you are seeing more Black people, more often than not, it tends to be severe so far as diabetic kidney disease is concerned. But the worrying aspect is that the majority of our patients might not die from end-stage kidney disease or from kidney failure. Within the spectrum, they are most likely going to die from some MI or from stroke or some other cardiovascular disease. And that is why, as we manage these patients, we should be on the lookout for some of these cardiovascular disease and manage them alongside. The natural history, we all know, basically, you think that, oh, typically patients will get to diabetes or they get to end stage 20 years, 10 years down the line. But the situation has changed. You and I will know that typically, as of the time you are seeing your first patient, they would have gone through the ladder already, and they already have a reduced GFR. So they are at risk of cardiovascular death. All the changes that we expect to happen so far as their kidneys are concerned have already started going on. There's some protein in their urine. They already have hypertension. And indeed, you see them when the GFR is already down. And indeed, most situations, you might even see them when they're already in kidney failure. And I guess you can bear with me on that. Now, the general principles of management, and indeed this for me is such an important slide in the sense that it summarizes everything. If you don't pick up anything that we are discussing, I beg, don't forget this slide. The general principles of management are to prevent or slow down the progression of kidney disease when somebody has diabetic nephropathy, or for that matter, diabetic kidney disease. Then again, like I mentioned, is to prevent the cardiovascular complications. So the KDIGO, in terms of their latest guideline in the management of diabetes 2020, actually used this pyramid, and I love so much. So if you are looking at this pyramid, look down here. This is actually the comprehensive strategy, where we are looking at what you already know. So this is not new in terms of glycemic control, blood pressure control, your lipid management. Of course, tell your patient to stop smoking. What are they eating and should they exercise? And this should be meted out to virtually every patient we have. Now, to most patients, and that is what we are going to spend most of our time talking about, where we are going to talk about SGLT2 and then RAS blockade and all in most patients. And then again, for those you are worried about, is it a stroke or they've had a stroke before or an MI, you would want to consider an antiplatelet. So this is an important slide, and we are going to talk more into details about this. Now, it is so clear that generally, targets is also very important. So we have always mentioned that indeed, when you are managing your patients with diabetes, we know that anytime you drop their HbA1c by 1%, you are getting a lot of benefit. So if you are seeing your patient with an HbA1c of 12 and you get it to 6 or you get it to 7, that's a lot of benefit. So the UK PDS study, which I guess we all know, actually showed this magnificent changes in terms of microvascular disease. That is where our diabetes will sit. That is any 1% drop in HbA1c, 37%, and that is whooping. And that is why glycemic control is super important. You decrease the risk of stroke, you decrease the risk of MIs, and then again, you decrease the risk of all the diabetes endpoints. So sugar control is super important. It is super important. But then the question is that, okay, let's control the sugar. But the question is, how tight should we control the sugar? Should we control it to an HbA1c less than 6, or we can keep it around above 7 or 8 and all? And these two large studies indeed summarize the whole thing. I mean, you have the advanced trial that actually had over 11,000 patients, and then the Accord trial of about 10,000 patients. And it was clear that indeed, if you are not careful and you want to target less than 6.4, because we know that sugar control is important, more often than not, your patients die from other causes, hypoglycemia, I believe. So that is why we need to watch it. But then the question is, if we are not controlling that tight, how should we control it? So again, KDIGO came out with this recommendation, which I found very important. And I think in your practice, you bear in mind that sugar control, blood pressure control, whatever control is patient specific. You need to learn to individualize your patients. I keep telling my residents, no two patients are the same. Look at the patient, look at where they are coming from, look at their comorbidities, and decide on what you want to do. And again, this is just a simple slide that tells us the important things. Are we getting less than 6.5 in terms of HbA1c in terms of target, or are we aiming for about less than 8? What should determine this? The severity of CKD. If you have a patient who is coming with CKD 1, 2, that's early enough. You need to be tight on the patient. If you have a patient who is coming with the end stages, 4, 5, so to speak, if you go too tight, you know what is going to happen. It's hypoglycemia, and they might not even get to you. They might die at home or die in a peripheral hospital. So how severe the CKD is very important. What macrovascular diseases are present? Are there only few? If there are few, go hard. If there are a lot of it, you probably are running into trouble already. Probably don't be too tight on these patients. And more of these patients will have comorbidities. They will probably have life expectancy that is shorter because they are older. The older they are, the more comorbidities they have, the more complications they have. Probably be careful. If you go too tight, you run yourself into trouble. Are they aware when they go into hypoglycemia? There are some patients, if you ask them to do their charts, they'll put charts with an FBS of 1.9 or 1.2, and they will tell you they didn't feel anything. If you have a patient like that, please be careful. Keep their HbA1cs in the 7s and play safe. If you go too hard, you're going to run into trouble. And then again, the propensity to cause a hypoglycemia. So these are key things you look out for as you are managing your patient. No two patients are ever the same. Now, in terms of, I will not bore you on this slide. I'm sure you have seen this slide. I just brought this slide to let you know that in terms of options for the management of diabetes, they are myriad. But nonetheless, metformin happens to be your king so far as type 2 diabetes is concerned. I'm sure somebody will throw it out there. Okay, how about when they drop GFRs? Do we stop metformin? I have my own opinion on it in terms of the benefits we get from metformin vis-a-vis, in quotes, the myth of that lactic acidosis, for which sometimes we stop our patients quickly from metformin, start them on glyclazide or sulfonylureas, and they are running into some hypoglycemia. I think we'll leave this for another discussion, but the point is that metformin is super important. If you think you have a reason not to give metformin, it has to be a tangible reason, and there are clear reasons why. Maybe in acute kidney injury, if you have overt, of course, lactic acidosis, yes, you will not consider, but nonetheless, it's something that you can use far into CKD 3 and even sometimes 4. Indeed, but then look at your patient and decide on what you want to use. So this slide has to do with if you are considering dual therapy, is the patient obese, yes or no? There are medications to consider over the others. And again, we're going to talk more about SGLT2. This is the new kid on the block, but trust me, it's not all settings that will have it available. But I think this slide is just to let us know that there are a lot of options. Options that you choose should be based on your patient. Now, what we realize is that sugar control, blood pressure control, lipids, and all of that were super important in terms of, the strategies that I mentioned. But we realized that over years, the only form of treatment that was considered helpful to prevent progression was ACE inhibitors and ARBs. So these studies, these were the major studies, the Renal trial and the IDNT. And these were done as far back as 2001. And as far back as 2001 until recently, we've never had any break-in medication that has been shown to prevent progression of kidney disease one way or the other. So all we've done, you see your patients, they have DM nephropathy or they have diabetic kidney disease, all you do is throw them some irbesartan, throw them losartan, and that is all. You keep watching them, and invariably they get into end-stage kidney failure, and you may have to dialyze them. So nothing changed in the nephrology world so far as diabetic kidney disease was concerned, and it was really a big problem. Now, what do we know? The point is that most of these medications we believe will be able to help the patients are based on the pathogenesis. So what we know is that when a patient develops diabetes, clearly, we know that, of course, there are genetic factors why they are developing it and why they will even develop diabetic kidney disease. There is also a genetic role. There are some, irrespective of what you do, one way or the other, they are running into diabetic nephropathy or, for that matter, diabetic kidney disease, and they'll go on dialysis. These things sometimes is difficult to control, but nonetheless, in terms of the metabolic stimulus, hyperglycemia, there's a lot we can do about it. Insulin resistance, that's where your metformin comes in strongly, and then reactive oxygen species, and then the hemodynamic situation, when hypertension gets in, your fluid balance, salt intake, and all, very helpful. But nonetheless, as patients were progressing in terms of microalbuminuria, what were the things that we're explaining? The signaling pathway was for us the solution to the problem. So we thought that, okay, let's look at maybe protein kinase C, the activated, glycemic agents. And then in any case, the tumor necrosis factors and all. All of these pathways are pathways that we believe that if we are able to stop VEGF, you are able to stop it, most likely you will prevent the renal complications. But then there are a lot of studies, which I'm going to talk about, which were done, which we didn't see anything. So though we know advanced glycosylated agents will put us into trouble, there was no way we were stopping it. Nuclear factor B was also a problem. There was no way to stop it. So you were still running into matrix accumulation, endothelial dysfunction, podocyte loss, basement membrane thickening, proteinuria, and so on and so forth. And invariably, your patient develops glomerulosclerosis, interstitial fibrosis, and that is it. We are in trouble. So then the question was that, how come all of these studies were negative studies? So from 2001, all of these things were explored. So we tried all of these mechanisms I've explained. Endothelial antagonists, we tried, it runs into trouble. We'll start from the lab rat, it seems to be working until you start in humans, and there's fluid overload, there's heart failure, mortality, so we're not getting anywhere. And I actually remember when, okay, we feel that the ACE inhibitors, ARBs, were the main thing. Let's double them. So you combine an ACE inhibitor and ARB, and we know it. Over a period, we realized that we were running into more trouble with hyperkalemia, more trouble into sometimes even deterioration of your renal functions, which again was not advocated. So it went off the market. So now what actually happened? We now believe that indeed the ominous octet, that's actually are all the mechanisms by which you run into trouble with diabetes. Now, increased lipolysis, decreased incretin effect, and all of those, I'm sure I won't bore you with all of these, but the most important point of this slide is to show you that now all of a sudden the kidney came up strongly to help solve its own problem. I love the kidney so much because yes, we create a problem one way or the other, and it's the kidney that you actually rely on to solve the problem. And ACE inhibitors did that, and of course now SGLT2s are also doing the same. And I'm going to talk more. So the increased glucose reabsorption was the mechanism. When it started off, the belief was that, of course, SGLT2 was helping to control sugars. We know the mechanism so well. So there's SGLT1 and there's SGLT2 at the proximal tubule. And about 90% of reabsorption is what happens with the SGLT2 that we know. So the point is that if we get our patients to pee more of the glucose, chances are that we'll control the blood sugar. The benefit again was that, of course, if the glucose goes, it's not small, which will not go alone, it will go with water, and the sodium that is also going with water. So it helps to control blood pressures. That was the idea into this medication. But nonetheless, we realized that it could do more than what we think. What else could it do? We realized that it could decrease the glomerular pressure. Of course, it could decrease the glucose. It decreases arterial stiffness. It decreases the volume. And the most important thing, which actually is the break, is the fact that it decreases inflammation and fibrosis. If you have any medication now that has the ability to decrease the inflammation and fibrosis, most likely it will prevent the progression. Apart from, of course, your albuminuria, the oxidative stress that we mentioned, the reactive oxygen species earlier on. And of course, it also has some effect on the angiotensinogen upregulation. So these were the proposed mechanisms by which we believe that the SGLT2s were working. And that is why it became the new kid on the block. Now, a lot of studies now went on. So from 2014 onwards, the EMPA-REG came, the CANVAS came, the DECLARE, but most of these earlier studies were targeted at cardiovascular outcomes. And indeed, you and I, our patients that we love and see so much, most of them were excluded. So they would take the, those with very good GFRs because they didn't want to run into trouble one way or the other. But it was Credence that actually came in 2019 that actually involved a lot of patients who had proteinuria, heavy proteinuria, and for that matter, decreased GFR. And that is what was a breakthrough in the nephrology world in 2019. Now, I've combined all the studies for the want of time to compare, and I'm just going to show you the highlights. What are the highlights? I mentioned the GFR. Now, look at it clearly. If you look at the Credence, in terms of those who come, what their mean GFRs were, they were lower GFRs. So DAPA-CKD and then the Credence trials, you have GFRs that are less than 60, which is actually our typical patients. The studies that were earlier on were looking at higher GFRs. Nonetheless, how about those who were, in terms of percentage, with GFR, with GFRs less than 60 or CKD3 and beyond? You realize that DAPA-CKD was doing about 89%, and then the Credence about 59%. So these were studies that are very important for us because there was heavy proteinuria, as we can see in the next highlights that I showed you, heavy proteinuria of greater than 300 milligrams, basically the DAPA-CKD about 90%. And indeed for Credence, it happens to be an inclusion criteria. For you to be included, you had to have a UACR of greater than 300. And that was very, very important. And most of the patients down here had a baseline RAS blockade. So they already had RAS blockade. And that is why I'm proposing, or I'm mentioning that, is it a triple therapy? So meaning that everybody should have a RAS blockade plus the SGLT2. And that is what we are talking about. So this is just to highlight some of the trials in terms of what we were looking at. So the empagliflozin, basically about 7,000 patients, 63 in terms of the age and HB1Cs that they were looking at, like I've mentioned. But my attention on this slide is what they found, basically. And you can actually see the clear differences, and these are the p-values. So far as those who were on EMPA, the EMPA study, they compared those even with 25 milligrams vis-a-vis 10 milligrams to placebo. And however you looked at it, there were severe, in fact, there was marked benefits so far as the use of EMPA was concerned in reducing cardiovascular outcomes, non-fatal strokes, non-fatal MIs. Again, here they were not targeting the renal, and that is what we should be particular about. Now, DAPA-CKD also came during the time of Credence, and it's important that when you look at it, you notice that now if you look at the kidney outcomes, decline in GFR less than 50, end-stage kidney disease, death from renal cause, and you compare, you will realize that indeed composite kidney outcomes were more in those on placebo vis-a-vis those who were on DAPA. Again, this was another study in the same class that showed clearly that among patients with chronic kidney disease, the risk of the composite kidney, cardiovascular, kidney alone, vis-a-vis placebo was phenomenal. And these are the things that I've shown. One thing I would want to mention to you is that if you look basically at the patient profile, again, you are talking about people with ACRs of 200 up to 500. And this was very, very significant. And now I'll take my attention to talk about Credence, which was actually the big one. What I would say is that I brought this slide to let us know how sometimes in interpreting some of these studies we should be watchful. Unfortunately, with the huge numbers, 34 countries at 690 sites, 4,000 participants, guess what? Africa had only 62 from only one country. And that is worrying. Indeed, I'll show you a few other slides about that also. That is the fact that if you're interpreting this, will the story be different if you are looking at Africa studies alone? Maybe not, but then sometimes it's good to be able to report the African story ourselves. Now, demographics, and I'm showing this to let you know proportion of Blacks. So if, like me, majority of your patients you are seeing as Blacks, get to know that it involves only 5%. So if it is only 5, meaning that the numbers are not great. These are those who are white and Asians making the number. And like I've mentioned, geographical wise, Africa had very few. Now, let's compare the study. So if you look at credence, for instance, those who are GFR less than 60 was about 60%. Those who had, UACRs greater than 300 were about what, 88%. So then the key thing is that this is the kind of patients you and I see. These are the kind of patients who will be sent to the renal clinic. And that is why this study happens to be very, very important. So I'll just take you through some of the highlights. We might not be able to go through all, but the highlights of the study. So the big outcome was the fact that, or the primary outcome was those who developed end-stage renal disease, those who doubled their creatinine, those who died from renal causes or from cardiovascular death, it was clear. And now what I want to show you basically is the fact that though there's a 30% reduction, and you can see that the graphs began to separate almost at 12 months. Now, why I'm particular about this is that there are a lot of patients who indeed, even when they can afford, they start off and unfortunately, 2 months down the line, 6 months down the line, they sometimes are expecting that this is an expensive medication. Doctor said a lot of things about it. Now that I'm starting this, the next 2 months that I come to show my labs, my creatinine that was, let's say, depending on the unit you are using, let's say 200 or let's say 150 will drop to 30. Or if you are using the milligram per deciliter, 2 will drop to 1 or maybe less. But mind you, that separation started almost at 1 year down the line. So that is where, and then you realize that the separation continued all the way to the 42 months that they follow these patients up. So the benefits are not instant. And these are the things you should let your patients know. Though it is clear that the risk reduction is 30%. And trust me, 30% is no joke. The losartan, the irbesartans, and all that we're using, the risk reduction was about 20%, but we are so excited about it. This is about 30, which is exciting to know. Now let's look at end-stage kidney disease, doubling of creatinine, and renal death. So when they took the cardiovascular death out, again, same. You can also see the separation again, close to 12 months, and they started separating, and the 34% risk reduction. And this is very important so far as our management is concerned. The p-values are sitting up here, and they are beautiful to see. It's so exciting to watch some of these studies. Then again, when we just look at end-stage kidney disease, so looking at just end-stage kidney disease, you start off your patient who probably was in CKD 3 or whatever. Those who developed end-stage kidney disease, the hazard ratio was 0.68. That converts to what? 32% risk reduction. Again, look at the point I'm trying to make. The separation didn't happen from 0, 4, 6 months. And indeed, somewhere around our hazard, around 8 months, that is when you are beginning to see some separation. Your patients may need to be patient. That is, patients need to be patient, of course. And then, but unfortunately, our patients are not patient. They want quick results. Doctors also want quick results, but be sure to know that the separation happens after a period of time. And indeed, you are talking about fibrosis, interstitial fibrosis, you are talking about inflammation. It takes a bit of time for you to see that change in your creatinine or in your proteinuria and all of those things. Now, when we talk about SGLT2, basically the side effects we are worried about are UTIs. I didn't bring that slide. I didn't want to bore you, but credence actually showed that UTI, there was no significant difference. But rather, I showed you this because it's the other side effects that were actually shown. So rather look out for genital infections, so mycotic infections. So ask your patients or check their urine for candida and so on and so forth. Those are actually the most important things so far as the side effect of this medication is concerned. And for some reason, some of the patients also tended to what? develop diabetic ketoacidosis for various reasons. I'm sure as they peed a lot and they dried out and all, so maybe it could account for. Those are the things to be particular about. But as you can see from this forest plot, anything that you see crossing, so you can see them in terms of all of these side effects, but in as much as they are crossing the zero, they are of no significance. So the one thing we should worry about are generally the mycotic infections. This is where urinary tract infection sits. You can see that there was no statistical difference, placebo, and then those who were on medication. Now, that was credence. That was SGLT2. As if that was not enough, there had been studies now into mineralocorticoid receptor antagonist, and finerenone is actually the new kid on the block. There was evidence to show in labs, there was evidence to show that there's some decrease so far as inflammation was concerned. And I've mentioned that if you're able to prove that a medication is able to decrease inflammation, just maybe it could help out. But some of the old studies that I showed you in terms of those that were hitting protein kinase C and all of those, they felt that, oh, it could help with inflammation. But when they put it to test, it failed. So I'm just going to take you through finerenone. These studies, the Fidelio DKD is happened to be the important study. It followed up with the Figaro, and I'm going to talk about these studies, and then eventually the Fidelity that combined the two, and I'm going to leave you for discussions. Now, this study, again, in the New England Journal, I'll just go straight to the point. They were looking at time to kidney failure, sustained decrease of greater than 40% of GFR, death from renal causes. And again, able to show that this medication, this medication, one way or the other, was able to reduce the progress, and it was significant. So you are talking about 17.38% vis-a-vis 20%. And this is time to renal failure, sustained decrease in GFR, and then the death from renal causes, it was significant. So the medication, which we believe was only for blood pressure control, unfortunately, finerenone and the plan, they failed in their blood pressure control, but nonetheless, they've been shown that, oh, they help a lot in terms of inflammation. And now we are looking at it in terms of a medication that will prevent the progression of kidney disease in diabetics. And then again, they looked at, those from death from cardiovascular causes, non-fatal stroke again, fatal stroke, and then hospitalization and heart failure. What else did they find? They again found out some significant difference, 13 vis-a-vis 14.8% with a hazard ratio of 86. What it means is that there's a 14% reduction so far as the medication was concerned, and this was brilliant. And I'm sure the moment I mentioned an aldosterone blocker or mineralocorticoid receptor blocker, the side effect that comes to mind is hyperkalemia. So what was the hyperkalemia situation? Yes, hyperkalemia that led to the discontinuation of medication was actually 2.3 vis-a-vis 0.9 in placebo. So definitely when you have your patients on finerenone, that is, if you have it available, I'll confess I don't have it here in Ghana yet, but if you have it available, watch for that hyperkalemia. Now the second, so these are, again, I brought the slide to show you the patient proportions. Now look at it. Again, blacks were what? Just 4.7%. Indeed, 5,000 patients, blacks were 4.7%. Again, we need to interpret it. But the beauty of it is basically the fact that it involved some chunk of patients with GFRs between 25 to 45 and even less than 25. So meaning that you probably can use it in your patients with lower GFRs. And this was exciting to know. But nonetheless, the lower the GFR, the more you watch what? That hyperkalemia. And this is very important. Then the Figaro. So Figaro targeted basically the cardiovascular outcomes. What did they find? Again, 7,000 patients followed by 3.4 years, death from cardiovascular causes, non-fatal MI, strokes, and all. What did we find? Again, a clear difference, 12.4%, and then 14.2% in the placebo. What it means is that it's a 13% risk reduction when you give your patient finerenone on their. Yeah, so very sorry again for the break in transmission. Unfortunately, the whole place is full now, so I couldn't get back. All right, so I was here when the battery went dead. All right, so cardiovascular outcomes, so I mentioned this, with 13% risk reduction. And then composite kidney failure, sustained decrease in GFR and all. I would say that this particular one, though it looked so nice, and indeed it included one. And as you know, if the hazard ratio includes one, it is not so significant. And you realize that even here, the percentages were close. So composite renal failure, decrease in GFR of greater than 40, death from renal causes, it wasn't statistically significant. But nonetheless, hyperkalemia again leading to the discontinuation of the drug, because the study was such that if it's just hyperkalemia that goes beyond a 5.5, they will stop actually the medication. That clearly was different in terms of 1.2 to 0.4. And this indeed was such an important finding. So like I've mentioned in the Fidelio, with Figaro also same. Let's just watch out for that hyperkalemia. Nonetheless, it's such a good drug. Now, then the issue was that, okay, the researchers of Fidelio and Figaro decided, okay, let's put the two studies together basically and see what we come up with. So they put clearly, so that like we know, the DKD significant reduction in the renal outcomes about 18%, and then the reduction in the cardiovascular events was 14%. Then the Figaro, like I mentioned, 13%. So there's just a repetition of the slide just to get the summary. So it was clear, but nonetheless, the last part was not significant, and that's what I just showed. Now they decided to put the two studies together, and they called it what? Fidelity. All right, so the Fidelity now combining the two numbers, and then they together and they decided to look at what the outcomes were. So this is actually what. So now the numbers were 13,000 patients that were followed up for 3 years, basically. And indeed, you will be recruited if you had a potassium of 4.8. So similar to what had been done. And now the point is, and this is why I want you to concentrate your energies on. So basically, the primary endpoint was, of course, time to occurrence of the composite outcomes, non-fatal stroke and all. And you can see that clearly there was a difference. So this phenomenon reduction and then placebo, 12 vis-a-vis 14.4. Again, cardiovascular outcomes, death and all, phenomenon shown that has been shown to be very helpful. Then the secondary endpoint was the composite. That is where this is what matters to you and I. The composite kidney outcomes, decrease in GFR and all of that. And you realize that indeed 0.77, that is actually super significant in terms of the numbers. You see the confidence interval, 0.67 to 0.88 with a very good p-value. So indeed, it's about 23% reduction, okay? Now look at it, those who had increase in hyperkalemia, clearly 14%, 6.9, like we already know, but those that led to permanent discontinuation of the medication above the threshold was only 1.7. So indeed, sometimes if your potassium is going up, watch it. Maybe you might not need to stop the medication. So I'll be done very soon. So basically, this is what I just summarized, the hyperkalemia, 1.7 compared to what, the 0.6. But then did the hyperkalemia lead to death? No. Everybody who actually, those who had the hyperkalemia, nobody died out of it. But let's be careful. These were followed patients. If you and I, our patients are coming from a very remote place, they are being seen not regularly, they might die from that hyperkalemia. So just be on the lookout for it in terms of Fidelity. Now, this is the summary slide basically. What are the drivers of diabetic kidney disease progression? Inflammation, definitely. And like we've said, inflammation, SGLT2s are playing an important role. Non-steroidal MRAs, of course, the phenomenon we've mentioned plays such an important role in the inflammation. And of course, our RAS blockade. If you are worried about inflammation and indeed you have a GLP, indeed you want to go for a GLP receptor antagonist if it's readily available and it's affordable for your patient, because that targets what? The inflammation. If we are looking at the hemodynamic regulation also, your AC inhibitors are still here, your SGLT2 and your MRA. So this is actually what I'm trying to call what? The triple therapy, because you realize that these three medications are super important, both in inflammation and hemodynamic dysregulation. Then, of course, we cannot do all of this when your sugars controls are not well, your sugars are not well controlled. HbA1cs are high, your FBSs are high. So, of course, sugar control is super, super important. What is the significance for Africa? Now, we need to have local studies for these medications. I personally believe in the availability of these medications in your practice. And that's why I want to hear from you. Do you have it available? Are patients able to afford? Are they able to go 1 year without complaining? Or what are they saying? Is it on your insurance scheme and all of that? I think I would want to hear from you also. And indeed, if they're available, are they affordable? That's also another point. If they are not affordable, they start off and they stop, and then the benefits are not accrued. And then how can we ensure that those who need the medication get it? And that is why, for me, advocacy is very important, to be able to talk to Big Pharma. If they will say the medications are as good as they are, let's get them into prices that we can afford and our patients can afford. So until then, let's prevent progression by sugar control. let's prevent progression by comprehensive therapy, nutrition, stopping the smoking, lipid management, blood pressure control. And indeed, I didn't spend a lot of time because you know this, tight blood pressure control vis-a-vis, relaxed blood pressure control. There are a lot of studies that actually show that if you are too tight, you run into trouble. High blood pressures, you run into trouble. And I wouldn't want to go into all of that. And then, of course, cardiovascular complications, where your lipid management, of course, stopping smoking, blood pressure controls are all important. So until then, these are still very helpful. If you do these things well, like I showed in the UKPDS study, you definitely would prevent a lot of things in terms of progression for your patient. So that is what leads me to Kidney Health International, and that is what we believe in, that is prevention. So this was just last year, World Diabetes Day, not even Kidney Day, Diabetes Day. Will take advantage to prevent the next person. Like we said from those studies, half to about 2/3 of your patients with diabetes are not aware. And it takes you and I to make people aware, catch them early, prevent them from getting progression, or else we are going to see them come die from MI, stroke, or from kidney failure. And having said that, in conclusion, diabetic kidney disease is a cause of significant morbidity and mortality. Let's aim to decrease the cardiovascular mortalities and decrease the disease progression by all this triple therapy, one way or the other, your sugar control, and all of these things I've mentioned. The general measures, in my opinion, are super important. As simple as they are, let's maximize them. And in my opinion, this SGLT2, the MRA, and AC inhibitors are the new kid on the block, the triple therapy that will help prevent our patients from getting kidney disease. And I believe that we need more studies in Africa. Having said that, thank you very much for your time, and sorry for the break in the, and sorry, I may have to get your questions also. Thank you very much. Lloyd.
Thank you very much, Elliot. It's a wonderful presentation, and it's state of the art, whatever we can actually get from the recent journals, all put together so wonderfully. Thank you so much. And especially the note on triple therapy, emphasizing on triple therapy. So the floor is now open to questions. Please unmute and ask, or please put into the chat box, please. You can either unmute and directly ask Dr. Elliot, or you can go into the chat box, please.
All right, I think I'm seeing one here. Maybe I'll jump at it. What's the difference between non-steroidal MRAs, that's finerenone, and your traditional MRAs in terms of aldactone? Would aldactone have similar protective effect? I'm sorry to disappoint you. And indeed, for the MRAs, so there's non-steroidal, indeed, it doesn't use the steroidal mechanisms, so spironolactone has to do with steroidal. So that's why you realize that it takes a bit of work, time for it to even zoom into action. It has a lot of evidence so far as, indeed, blood pressure control is concerned. It has a lot of evidence there, but in terms of inflammation, it was not necessarily so. So indeed, they've not been able to show similar like the finerenone. That's why the attention. The finerenone, like I mentioned, the effect was more into inflammation, but blood pressure control is also FWACP. So that is the difference between the two. Yeah. All right. So somebody is saying thank you. Yeah. Can MRA still be used in diabetics who have normal blood pressure? Yes, they can indeed. And that's all I mentioned. They are not too great. And indeed, like you bear with me, even your AC inhibitors, ARBs in blacks, they are not that blood pressure control pill, so to speak. We give them because of their added prognostic benefit for the heart, for the kidney, for the brain, and so on and so forth. But indeed, if you give it to your typical black, it doesn't drop the blood pressures. On the other hand, for Caucasians, if you give them some lisinopril or AC inhibitors and they take it in the morning, they are getting all these postural hypotensions and all. And these are the things that are important. Nonetheless, they are not too great for blood pressure control. I think we should mention that. So if your blood pressures are normal, just like you give for your diabetes, with AC inhibitors, is the same. You can still give it. Can we combine losartan with finerenone? Fantastic. We can always combine. But nonetheless, the caution is that your blood pressure, your potassium is a place to be watching. So if you are watching your potassium, you are safe. If you are watching your potassium and you don't run into any trouble, you can keep giving it. But nonetheless, what I've realized clinically is that if you have a patient with very good urine outputs and all, most likely they'll be able to get a lot of rate of that potassium in their urine. So you don't run into trouble. And of course, if you are running into trouble, you may have to advise them on diet and so on and so forth. But the belief is that you definitely need to be on an ACE inhibitor on ARB. You definitely need to be on your SGLT2 because it's of added benefit. And we believe, and that's what I'm calling the triple therapy. And then you add this to the two to get your triple therapy, which we believe will be able to prevent the progression. All right, so MN is saying, what's the mechanism by which SGLT2 reduce inflammation and fibrosis? How I wish I knew the mechanism. So like I said, we knew clearly what it does in terms of the kidney. It prevents you, or it absorbs, the glucose. So if you inhibit it, you prevent glucose absorption. But why it will do inflammation? And it is similar, again, to ACE inhibitors, ARBs. We know, okay, it has to do with RAS. And all we believe is that, oh, the RAS in itself has to do with inflammation. So when you block RAS, you also block inflammation. And I think that is all we know. But the hardcore mechanism, if you get it, I'll be happy to also know. We are not too sure. It's just hypothesis now. Is there a GFR below which finerenone cannot be used? Like I showed you in the study, indeed, you have proportions of patients where GFRs of less than 25 were still given finerenone. So as it stands now, I'm not sure we have clear guidelines on when you cannot use it. I think the only roadblock basically is the hyperkalemia. So let's just watch that hyperkalemia closely. Other than that, I'm sure it will be fine. Dr. Ladui, okay, thanks for your energy. Thank you very much. I'm hungry now. Would you give SGLT2 in a 27-year-old non-diabetic? Aha, okay. So I like that. Thank you, Maza. So indeed, we've talked about diabetics, and indeed, when SGLT2 came, I'm not sure I had time to talk about all of these. When SGLT2 came, it was, oh, diabetics. Honestly, if we in fact, or kidney disease, should I say, but if we don't take chances now, the cardiologist will start writing more of SGLT2s and finerenone more than us. So indeed, these studies were done. So yes, in terms of confidence, we know this is for diabetics. But I believe just as SGLT2 started with diabetics and then now started looking at non-diabetics, I believe clearly that maybe it would have benefit. But I think we need to watch the space. But I will not be surprised at all. And indeed, if you have it available and you are running into trouble, I believe you can give it to your patient. But nonetheless, we don't have clear guidelines. I'm believing with all these new things that are going on, our guidelines from next year are going to change big time. I believe so. So let's just watch the space and then be able to help out. Oh, the questions are flying in. Okay, great presentation. Can we use SGLT2 in diabetic with on constant hemodialysis? Do they have any effect? All right. I'm not sure the studies were done in people on dialysis, but these were studies that were done to prevent your patient from getting onto dialysis in the first place. So it's the same argument that will be held in, if your patient is on dialysis, would they still benefit from ACE inhibitor? Is your patient is on dialysis, would they still benefit? It depends on what you are looking at. If they're already on dialysis, what is the benefit? So I think it will be risky sometimes with the hyperkalemia and all of those things. So I don't have a lot of evidence for it. I'll be happy to hear any evidence anybody has. All right, so thanks, informative, yeah. Lowest GFR for which SGLT2 is seemed to be used at lower GFRs now. Yes, it is. Oh, okay, I think Lloyd was trying to answer that question. Yes, it is, because now we know that you can go lower in terms of GFRs, again, depending on what you want to achieve. If your kidneys are all gone and probably there isn't much to salvage, you are just going to run yourself into more trouble. But most of the studies are now pushing to look at lower GFRs, like I showed you in the Credence and the DAPA DKD. All right, hope we can receive this presentation through emails. I'll have a discussion with Lloyd about it. I'm sure it shouldn't be a problem. Any role on ARNI? I'm not sure. What is it supposed to be? I'm not sure what this is. ARNI, if anybody knows, just let me know. In preventing diabetic nephropathy, great presentation. Is there any advances in therapies for DKD targeting protein kinase C? Yes. So I talked about the protein kinase C and the age pathways. Most of the studies, my brother, they were negative. So there were a lot of studies that went into it, but most of them, it was actually one of the slides. So if I share it, maybe you see it. They were all negative. These so far are the positive, and indeed that has been shown to have some benefit. But most of those studies were negative studies. Okay. So it will be interesting to have a trial of SGLT2 versus a combination of SGLT2. That would be wonderful, Lloyd. Yes, and indeed, most people have argued that the benefit of the SGLT2 maybe was riding on the ACE inhibitor already. So it will not be a bad idea to have a study like that. And I believe that it's something Africa we can look at and have our own study where we are comparing ACE inhibitors alone or SGLT2 alone vis-a-vis SGLT2 plus ACE inhibitors. So I think that would be a great study. Thanks, Lloyd. Did you suggest that metformin can be used in patients less than with GFR less than 30? This is my personal opinion. I'm entitled to it. There's no guideline that would agree to what I'm saying. But what I've realized indeed is that the reasons for which we stop metformin are so premature, in my opinion. And there was a large paper that was DeFronzo and all that put together to say that the metformin issue, lactic acidosis, is a myth, and I buy into it. If you have your patient who's bicarbonates are not in trouble, you don't have lactic acidosis, you don't have a new AKI, it's a stable patient TKD. Personally, and again, it's my personal opinion, I sometimes push to the limit. I'll keep doing until I have a good reason to stop the metformin, because again, of that wonderful benefit of metformin. All right. Okay, good. I think somebody is educating on the ARNI. All right. So indeed, that combination has been used. Indeed, heart failure is a wonderful medication, fantastic medication that has been given. Do I have a lot of evidence for diabetic kidney disease and in terms of progression for kidney failure? I am not sure I have for the sacubitril and the valsartan. And again, the valsartan is sitting there. Let's not forget all the problems that can happen so far as potassium is concerned. I think it's 5 o'clock now, and I probably may have to hop into another meeting, but the questions are coming fast. Good people are generally afraid to, yes, SGLT2 are good, but people are generally afraid of the drug.
Question.
Yeah. So maybe, I think this is actually, it was actually a comment, or is it a question? Yeah, great talk. Seems very good. People with diabetic already advanced complications. Yeah, I think there's also a, yeah. So Lloyd, thank you very much. I think thank you for the participation.
Yeah, thank you very much.
I fell out of my own presentation and I couldn't come back because it looks like a lot of people were hoping to come in, or the whole place was full. So maybe Africa Healthcare Network, please, you have to maximize the numbers because people love your presentations. Thank you for having me, guys. Thank you very much.
Yeah. Thank you very much, Elliot. Thank you very much. It was a wonderful session, a lot of good questions, and I think all of us enjoyed it, and the house was full today. Really, the house was full. Thank you so much, and we will have you back again.